My name is Andrew Sarazin at the Bill and Melinda Gates Foundation. Thanks for everybody for attending this session. It's the final plenary session of our events today. And, you know, we wanted to leave you, I think, with a sort of sense of inspiration and, you know, sort of, one has the feeling of preaching to the choir, I think, for this session. But we've heard over the past few days about really both personally the aha moments that people have had when they thought of the idea, and the aha moments that continue to emerge, I think, over the past few days when people are implementing their projects and something emerges out of that, and how important it is to recognize those. So for this session, we'll start with a personal story about a family and a company associated with that family and their journey to newborn and child health, and then sort of expand the focus a little bit to talk more generally about creativity and what we're learning sort of about maybe about the science of creativity and inspiration, and then how systems are organized, or how people are organized in systems to maximize that creativity. And then bring it back down to a more focused level, again, back on maternal, newborn, and child health. So that's the sort of the session for today. We're going to start with some, the presentations will be between sort of 15, 18 minutes. We'll have time for a few clarifying questions. And then after all of the speakers finish, we'll have them occupy the stage here, and then we can have a more full discussion. So we've got plenty of time for discussion. So the first speaker is Tore Laerdal, who is an interesting story is that those of you who work in maternal, newborn, and child health are very familiar with him, and he's a fixture, I think, on the sort of world stage here. But that wasn't always the case. Actually, it was only 2008 when that he had really come to realize and focus specifically on maternal, newborn, and child health. And Tore is the managing director of Laerdal Global Health, which is a company established in 2010 with the sole purpose of providing affordable and culturally sensitive training and therapeutic solutions to reduce maternal and newborn mortality, both at the day of birth in low resource settings. He's also the executive director of the Laerdal Foundation for Acute Medicine and chairman of the board of Laerdal Medical, a family-owned company that for 50 years, and we'll hear about that, has been a leading supplier of training, material, and therapeutic equipment for acute medicine. So with no further ado, I'd like to introduce Tore.
Good afternoon. My name is Tore Laerdal, and I've been asked to share with you a very personal story, and I do my best. Nurturing the aha moments. Here in Seattle, you are celebrating the 50th anniversary of the Space Needle and the World Fair. Our story goes further back to 1888, and that was the year the Eiffel Tower was being erected in Paris for the World Fair in that city the year after. In that year, a young girl is found drowned in the River Seine, and nobody knows her identity, so a die cast is made of her death mask for identification purposes. Her identity remains unknown, but her enigmatic smile made this an intriguing story for authors and painters in decades to follow, and the story has lived on. The author Albert Camus referred to her as the drowned Mona Lisa. BBC Radio made a extensive documentary on this story a few years ago, and as late as last week there was the premiere performance of a stage play called L'Inconnu, or The Unknown, in London, that I had the pleasure of attending. So let's go forward to the late 1950s, and some remarkable discoveries are made at the Johns Hopkins University in Baltimore. Researchers are actually giving birth to modern resuscitation, or CPR, and they are redefining death. Until now, death has been supposed to be when a human being is stopping to breathe or the heart stops beating. And now they discover that this is still a few precious minutes before the brain cell starts to die, and the death, or the biological death, is occurring. And most important, this is a reversible process. So let us have a quick look at some video clips from those discoveries.
Dr. Safer knew that the chest or back pressure methods did not work.
We know as anesthetists that you have to do certain tricks with the head, jaw, neck to provide an open air passage. Nature wasn't good to us. Most animals have straight air passages, so when you push on the chest, you can move here. Humans have a kinked air passage, so when they become relaxed in coma or anesthesia, total obstruction.
Safer enlisted Captain Martin McMahon, who was in charge of the Baltimore City Fire Department's ambulance corps. McMahon enthusiastically joined Safer's experiment. He provided firemen to test the new method. Dr. Safer provided the victims. 39 physicians, medical students, and one nurse courageously volunteered to be sedated, fully paralyzed, so their normal breathing would stop, and have a dozen laypersons try various techniques of artificial ventilation to see what worked. Dr. James Jude worked at Johns Hopkins on a cardiac research team headed by Dr. William Cowenhoven.
Dr. Cowenhoven.
They made a surprising discovery quite by accident. One member of the team, Guy Knickerbocker, found when attaching the electrodes to the dog.
With the pressure of the electrodes on the chest, there was a blip in the blood pressure. So he told me about this, and I said that was very interesting. And he continued with some of these studies and found that if he pressed and substituted his hand instead of the electrodes in the heart being in this quivering activity, the blood was being circulated. You could go up to 30 minutes and still have a dog which was perfectly normal.
Knickerbocker, Cowenhoven, and Jude began experimenting on the best method to maintain artificial circulation. Cowenhoven and his team emphasized chest compression. Safer and Elam, mouth to mouth. The two techniques came together, and at a conference in Ocean City, Maryland in 1961, cardiopulmonary resuscitation, CPR, was born.
Now at that time, my father, Asmund Laerdal, was a successful toy manufacturer in Stavanger, Norway. He had just introduced the Anne doll, which actually was the first doll to have stitched hair, sleeping eyes, and soft unbreakable parts. He heard about these discoveries of CPR from some doctor friends, and now he became almost obsessed about the idea of making a life-size, lifelike doll to help disseminate these techniques to the general public. He was motivated by a personal experience, a near drowning in the family, and a very, very strong entrepreneurial spirit. But how should he make this doll that should motivate the population at large to blow into a person who until now had been considered dead? It needed to be realistic but not scary. So he had an aha moment when all of a sudden he stares at this mask, of all places, at the wall in the living room of his in-laws. He gets intrigued about this enigmatic smile, as so many others. He studies the story, and he asks the sculptor to modify this mask to make it functional for this resuscitation mannequin, and the unknown becomes Resusci Anne. He contacts a local anesthesiologist for advice on anatomical correctness, and then he travels to Baltimore 9 months later, bringing a prototype and visits with Peter Safar. The two of them clicked and became lifelong friends, and in 1960 Resusci Anne was introduced. At that time it was primarily focused on drowning victims, and here you see my father actually practicing with Resusci Anne. Now, 50 years later, in 2010, when the when there was the golden anniversary for CPR, the American Heart Association estimated that 300 to 400 million people had been trained, and most of them on Resusci Anne mannequins. It was also estimated that as many as 2 million lives may have been saved as a result of CPR. Our company continued to make toys up until 1978, 3 years before the premature death of my father. And today, we're a company with around 1,500 people. We operate in 26 countries, and we are fully focused on our mission, helping save lives. Have we learned anything over these 50 years that may be relevant for saving lives at birth? Yes, we have. And I believe in particular 4 messages. This is an illustration of the Utstein formula of survival, suggesting that survival relative to the maximum chances is a product of 3 factors: the medical science multiplied with the education efficiency, and then again multiplied with the local implementation. I'm glad to share with you, for those who may not know, that Seattle today is considered by most experts in the world to be the best organized EMS system in the world. And you have a high score here on all 3 of these factors. Say, for example, 80% on all of them. It's a balanced, strong formula here. And that produces 80 times 80 times 80 is 50%. In other words, 50% of the maximum, which is based on current evidence about, it's expected that as many as 40% could survive. So in Seattle, 1 out of 5 sudden cardiac arrest victims walk out of hospital in good health condition. Now, this is not the case in most communities in the States. The average is considered to be around 7 to 8%, and the worst in class have a survival rate of no more than 2%. Now, note the difference in the scoring here. The medical science is the same. They have the same guidelines, they have the same teaching books, they have the same equipment in the hospital, and they have the same equipment in the ambulances. So this formula is suggesting that for medical science to benefit patient survival, it needs to be coupled with efficient education and efficient local implementation. I'll revert to that. We have, over these 50 years, produced a number of different mannequins, of course, and Resusci Anne has been evolving with the evolving needs. And another learning or lesson learned is keep it simple. So here is an example of Mini Anne, also using the face mask of the unknown, which is a $30 personal kit that's typically sponsored by an insurance company or some other organization, given to the students at school so they can take it home and train their parents. This is a very hands-on video coached training that takes 20 minutes only, whereas in the 1960s, the CPR course took 6 hours. The educational efficiency is higher. The third lesson is that day of birth is the greatest opportunity also for CPR to save lives. And in particular then in the developing countries. That made us start a collaboration with the American Academy of Pediatrics, who has been leading newborn resuscitation training for decades. But in 2008, they invited us to collaborate to make a much simplified course to train hundreds of thousands of birth attendants in developing countries in the bare essentials. And this action plan that you see to the left is somewhat different from most other algorithms. It's highly visual, and it's color-coded using the same colors as in the traffic light. 10% of all newborns, whether they are in Seattle or they are in Sierra Leone or in Bangladesh, around 10% need some stimulation to start breathing. Those are very simple steps, and they're taken for granted in the developed world. Unfortunately, they are not well communicated or understood in developing countries. So many babies are tragically left alone. And this golden minute where the traffic light is in the yellow sector shifts to red because nobody is doing anything, and the situation gets worse and the baby dies. So this course is based on teaching 3 very simple steps to help the baby that is born in the yellow traffic light sector to shift to green instead of shifting to red after the golden minute. We made then these illustrations for the course, and we developed a very low-cost newborn simulator, which I'm having here, and it's on several stands. Neonatally, we have been making sophisticated simulators for several years. We have baby simulators used in Seattle and other rich sites, costing up to $30,000. This one's costing $50. And it is not a plastic dummy, it's water-filled. It can have the temperature you like. You need to support the head. It has some bulbs, so that this can be a simulation training, because if you squeeze one of the bulbs, the baby will be breathing. If you squeeze, as the instructor, another bulb, there will be an umbilical pulse, so that the students can train going through the various scenarios and learn how to save that baby. And next Tuesday, there will be the second annual meeting of the Helping Babies Breathe Alliance, which will be then summarizing the results of this project, which is now rolling out in 48 countries. And by now, it's estimated that the first 100,000 birth attendants have been trained. The goal is to train 1 million birth attendants in this Helping Babies Breathe course by 2015. And more encouraging even than the numbers, of course, is the impact. And there are now evidence from Tanzania, where there's been a study at 8 hospitals after training. And based on 78,000 deliveries on these 8 hospitals, there is a 48% reduction in birth asphyxia. There is a 20% reduction in the misnomer, fresh stillborns. And there is also impressive numbers that are not exact on additional impact because in addition to those babies that are dying, there is an equal number of babies that are being brain damaged for life because they have compromised breathing during delivery. Let me go back to this, which is an aha moment for me personally, because in traveling with representatives of the American Academy of Pediatrics and this alliance that was initiated by the USAID to implement this, I really realized that not only were there very, very big numbers that could be saved, but the impact in life years saved would actually likely be more than tenfold as big as is now being realized after training of 300 to 400 million people in CPR every year. How is that possible? Well, the estimate is that there is around 800,000 babies dying from birth asphyxia. And there may be a potential, if well implemented, to save up to 50% of them. But in addition, if you're saving a newborn to take the first breath of life, you're saving more than 50 life years. As compared to saving a cardiac arrest victim, which on average would be 68, 69 years, and have a underlying disease, you wouldn't save that many life years. So really this was an aha moment to me, and that led to the establishment of Laerdal Global Health. What you see here is the first official save, Shifa in Bangladesh in late July of 2010. She was saved by a birth attendant up in Sylhet who had taken the course. And she became the symbol that we have reproduced in that logo. The logo otherwise is exactly like Laerdal Medical's logo, but that has two male, showing sort of a symbol of the Good Samaritan. That would not be appropriate for maternal and newborn health in developing countries. Also, when we saw this success of the Helping Babies Breathe reaching these birth attendants, it didn't take an aha moment to realize that if we could reach those birth attendants being there at delivery, they should also be prepared to save the mother. So as everybody in this room will know, saving lives at birth, there may be a mother, there may be a newborn, who is the patient. And there are very simple steps also to prevent the mother from dying, in particular from postpartum hemorrhage. So we developed then another course with Japaigo, which is now undergoing field testing in India, in Malawi, in Tanzania, at Zanzibar. And that is using Mama Natalie, which is also on display here. And you see that is a wearable birthing simulator. That's very important to be culturally adapted to the needs in developing countries. You shouldn't have a plastic body of a mannequin that is on the table, which is then simulating to be the mother. You should have a talking mother because communication training is very, very important as part of this course. The focus at Grand Challenges is perhaps first and foremost on concept solutions, early good ideas that are being discussed then for seed grants and then transition grants for scale up later. But a very, I think, important quote from Michael Schrage is that innovation is not what innovators do, it is what's being adopted by customers. So back to this formula survival, it doesn't make a great impact to make a medical science discovery unless it is reaching the patient by improved treatment. So there need to be attention to the full innovation process, the full business process, and that is, of course, the challenge that is awaiting many of the projects being discussed here. And if we look at the barriers to global health innovation, like we saw with this formula survival, the barriers are typically most to the right of this arrow in implementation, and therefore it is very important that you have focus on that. So the fourth lesson we have learned from implementing CPR in 50 years is that you should collaborate to innovate. And let me give an example with a second alliance we've been privileged to establish with Japaigo and the Center for Bioengineering, Innovation and Design at Johns Hopkins, called the Day of Birth Alliance. Japaigo would have its relative strength in the needs assessment and in the implementation. CIBIT is world-class when it comes to using technology and new conceptual solutions. And Laerdal Global Health can then capitalize on 50 years of experience in industrialization and implementation and business model. So the three partners have synergistic capabilities and competencies, and that makes a perfect basis for collaboration. We also have a third alliance that was launched at the Child Health Summit last month by Secretary Clinton. And she stated that every child should have the right to a 5th birthday. And then she posted a photo of herself at the website of Every Woman, Every Child, along with a number of other dignitaries' photos at 5. So here's me at 2. The photo taken a few days after I was saved by my father from a near drowning. So maybe I was an aha moment for him later on, or at least a contributing factor to it. And here is my own son at 5, practicing on Resusci Junior, which is a junior mannequin, which is modeled after his own body at 5. So, to sum it all up, nurturing the aha moment, to me, based on these experiences we had, is focus on education and implementation. Keep it simple. Day of birth is the biggest opportunity, and innovate through collaboration. Thank you very much.
Take a few questions right now. That was absolutely wonderful and inspirational, and you can sort of see how, you know, business has shifted as new realization has happened, and that's combining a sort of wonderful personal story with an organizational vision that's now reaching millions. So really thank you. So we have time for a few questions. We're going to have some time for questions at the end with all the panelists, but a few questions just to start.
Thank you so much for that personal story. In our last session, we had a comment about, well, I can't get anybody to fund this because big companies don't want to develop this because there isn't enough profit. So congratulations on taking a $30,000 product down to $50. What do you say to other companies who may not have your personal motivation or history about that extreme affordability and reaching the millions of people who you see as customers or a target market that they may not?
It's not an easy answer to that in a sentence or two, but I think we came to realize that if we wanted to have an impact, and an impact by 2015, it needed to be both very simple and very affordable. And global health is probably going to make out less than 5% of the turnover of Laerdal in total. So we could take the sort of economic autonomy of the company, and we could make a commitment to do what we felt was necessary to have an impact. And I also feel that this is certainly not only a philanthropic thing, and we're making this actually on a not-for-profit basis, this company. But I think this is contributing a lot of pride to our 1,500 employees. And if we're successful in this, it will also somehow reflect on the brand value of Laerdal globally. So I think that what it takes is a commitment to a mission and a long-term perspective, and not sort of a 3-month tyranny of much of the publicly traded companies.
Other questions?
Thank you. That was really inspiring. On number 4 about innovating through collaboration, I was wondering if you could share some wisdom on how to choose collaborators or how to identify collaborators, because it seems like who your partners are and how you work together seems critical to moving the aha moment forward.
Yeah, we have been blessed with a close working relationship with the people that have led the medical science in this area for decades. We have already for years been a strategic partner with organizations like the American Heart Association, the American Academy of Pediatrics, National League of Nursing, and others. So we had established a kind of awareness and trust. So when the American Academy of Pediatrics made the commitment to make something that was tailor-made for the birth attendants in developing countries, they had already the expectations that we would be a value-added partner, and they invited us, which of course is a privilege you have in building stone on stone for many years. But I would like to add that I've been very impressed with USAID and their approach to global development alliances and private-public partnerships. In other areas, we are meeting sort of suspicion and attention to conflict of interest. USAID has had a different approach, and they are really chasing private partnerships. And I think that has been very, very rewarding to work with them.
Thank you.